these rescue medications more than the actual costs of these rescue medications.
Well, thank you. At this point, we're going to go to public comment, and I believe we have one commenter, Nancy Newell. Is he here? Oh, yes. Please come up and introduce yourself and state any conflicts of interest.
Thank you very much.
I'm Nancy Newell, and I'm a angioedema patient, and I don't have any conflicts of interest, really. I've kind of written out a brief summary here of my menopausal angioedema hell. Allergies is how this all started out, being tested for, or bug bites. In desperation, I can remember taking everything out of my room and throwing it in the backyard because I was told it could be detergents, something in my deodorant, hair products. When I went to work and told the dentist that I worked for, he thought I needed to take some time off and figure this out. At that point, I did feel like I was losing it. I was intentionally eating things on my days off, trying to find a reason for my facial swelling. Other swellings I could hide. But 99% of the swellings were when I awoke in the morning. And how stressful is sleeping? From being told it was in my head and I should be able to control this with yoga and meditation, to a psychiatrist giving me horse hormones, Lexapro and Adderall because of my depression. Neurotic is still a word I see in front of angioedema. To this day, the first thing I do is feel my face and lips with my hands when I wake up. Since 1995, I started working in a small dental office. Loved my job and the dentist and the other girl in the office. Just a small practice. I was a single mom with 2 kids who both thought I was losing it too. My job was close to the kids' school, close to home. First swelling was in 2000, the day my daughter graduated from high school. I did go to the ceremony saying it was a bug bite. My job worked around me in the back lab and wearing a mask. By 2003, the frequency of swelling became overwhelming, and so often that another girl was hired. Patients kept asking if I was contagious, and I became the topic of conversation for all the people coming in for dental treatment. You can only say it's a bug bite for so long. As my friends stopped calling to go places because I canceled so often, I actually did have a social life with a boyfriend. He stuck around for a while, but I wasn't much fun at this point. Wearing bug spray as a cologne because one of my worst, fastest swellings ever came from a mosquito is not an appealing aroma for a guy. Used to enjoy camping, boating, and outings prior to this, but losing my job in 2003, followed by losing my home, cashing my retirement funds in early with pennies on the dollar, my credit was totally gone because of my medical bills amounting to hundreds of thousands of dollars. My dad helped me out for about a year with the payments of my home, and then it was suggested to move in with him and his wife, and that lasted for about a year. I moved in with my brother, who went on this awful journey with me, as morning after morning, waking up with swelling, either my face, hands, feet, or even my privates. Depression set in bad, and in bed for months with no diagnosis. I passed the civil service post office job thinking of occupations that had little public contact. I started in a nearby city, almost made it through the training until the 3rd time I showed up, swelled. The good thing about that attempt at making a living was I actually got an interview with Social Security and realizing I had medical issues. In 2009, I started to receive disability benefits of $800 a month. Over 50 ER visits in 2004. I was only going when my throat swelled. It was amounting to 20 out of 30 days each month. My daughter was helping me to be my own patient advocate. She could speak with me on the phone and know I needed to go to ER. I lived with her for a while and took a course in sterile processing. I thought, what better place to work than in a hospital? I did complete the classes, passed the certification, completed the externship, but still dealing with swelling and no diagnosis. I was never hired at a hospital. In 2008, I found myself admitted to the hospital for heart problems, and then was where I first heard the angioedema word, from an intern who had done an externship with Dr. Schultz and Jacobs in Walnut Creek, which was only 25 miles from my home. 2 weeks later, the blood work came back from Dr. Jacobs' office, and it came with positive results of the angioedema, and I was thrilled to tell my kids it was not the hereditary kind. But as rare disease disorders goes, lucky me, I had the rarest of the rare disease, type 3 angioedema, or an acquired, as it is known. I called HAE Association and Lois, who to this day is my angel, also a patient of Dr. Jacobs. I had some reality that I was not the only freak in the world. That's what my family referred to me as for years, knowing somewhere someone else had to have had experienced these similar symptoms. As my brother dropped me off at the airport to my first HAE conference, he said, "You're going to go meet more freaks like you." And what a reality check that was. Here I'm dealing with my medical issues, and I now refer to them as angioedema menopausal hell. At the summit meeting were adults and kids and children, a lot of them. Angioedema as a child, a real eye-opener. I now still live with my brother, and after several meds, I have injections of Zolar every 4 weeks at the cost of over $2,000 each month. I have Medicare and HealthWell Foundation that help pay for some of my medical expenses. I can afford $50 each month. Disability pays me $921, $100 of that is taken out for Medicare. I pay Dr. Jacobs' office $50 each appointment, and my balance for Dr. Jacobs' alone office is $133,595 as of the end of last year. And my credit rating sucks as a result of all of this. Thank you.
Thank you for that. At this point, we're going to ask our manufacturer representative to come up to the main table. Dr. Deborah Benson-Kennedy, and again, please declare any potential conflicts of interest before speaking.
Thank you. My conflict of interest is I work for CSL Behring. I think it's noted appropriately in the documents. On behalf of CSL Behring, I would like to thank you for the opportunity to comment on a number of issues we believe should be considered regarding the evidence report. Haegarda is the only C1 INH subcutaneous injection for prevention of HAE attacks. In the pivotal trial, Haegarda demonstrated a 95% mean reduction of HAE attacks compared to placebo, and showed a greater than 99% median reduction number of uses of rescue medication compared to placebo by the subjects in the 60 international unit per kilogram treatment arm. CSL Behring has a long history of delivering innovative therapy solutions to patients and physicians treating hereditary angioedema, and is committed to help meet the unique needs of those living with HAE. For that reason, we believe that it is important for physicians to have therapy options available for patients living with HAE, and that all therapy advances for this rare and life-threatening disease are important to the HAE community. CSL Behring agrees with ICER's overall conclusion that Haegarda is a highly effective prophylaxis therapy and more cost-effective medicine compared to Cinryze lower fixed dose of prophylaxis therapy and the monoclonal antibody therapy for prophylaxis. In reference to ICER's cost-effectiveness model, CSL believes that the reduction in the assumed number of attacks in the model underrepresents the number of attacks suffered by HAE patients. We believe that the previous weighted average of 3.8 attacks per month is more reflective of real-world experience, and the efficacy seen for Haegarda in the phase 3 clinical trial is based on a more severe population of patients, and thus the efficacy in the trial should be used in the context of trial-based number of attacks per month, which is 4.0 attacks per month. We recommend that Haegarda's phase 3 clinical trial efficacy data be utilized in your cost-effectiveness model calculations because it is a crossover design where patients served as their own control. Therefore, the finding of 4.0 monthly attack rate during the HAE patient's placebo period was a true reflection of the HAE patient's disease severity, and that a reduction to 0.5 monthly attacks while on the 60 international unit per kilogram treatment arm was significant both statistically and clinically. We're concerned that Haegarda does not receive added benefit in the cost-effectiveness model for reducing not only frequency, but also severity of acute attacks. Haegarda was the only product that showed a decrease in severity of attacks. HAE is a lifelong genetic disease with certain patient population benefiting most from prophylactic therapies. We believe that the long history of C1 INH replacement therapy safety and merits of Haegarda's clinical trial results need to take precedence over therapies with unknown long-term safety and efficacy. Furthermore, CSL agrees with ICER's assessment that there is inadequate evidence to support Q4 weekly dosing of the monoclonal antibody therapy for prophylaxis. Lacking evidence, the idea transitioning patients to monthly dosing is speculative and runs counter to ICER's mission of evidence-based analysis. Over a period of time, all therapeutic monoclonal antibodies can elicit an immune response with consequent production of anti-drug antibodies. In patients developing high-titer anti-drug antibodies, a substantial part of the drug will be neutralized, and clinical and non-response is likely to occur. Thus, there is sufficient evidence to demonstrate that patients taking monoclonal antibodies tend to require increasing doses, further supporting the idea that decreasing doses for long-term treatment is speculative and unlikely. Revisions have been made to the percentage of patients requiring dosing with on-demand medications, and some significantly. These revised percentages are not in line with our observations in the compact HAEGARDA clinical trial, where 24% of Firazyr patients required redosing, along with 14% of Ruconest patients and 4% of Berinert patients. CSL would also like to better understand the inclusion of wastage within the cost-effectiveness model. While wastage of vials is an important consideration when dealing with cytotoxic treatments like chemotherapy, that is much less true when dealing with plasma-derived therapy like C1 esterase inhibitors. It is common for HAE patients to not discard any potential remaining product as they typically administer the entire vial. HAE patients are utilizing and benefiting from the entire prescribed body weight dose, correlating higher C1-INH levels with a lower risk of angioedema attacks. There has been no identified or reported safety concerns with administering more C1-INH than the intended dose. In fact, there are dose-related benefits of achieving higher C1-INH functional levels, nor are there data to support safety and efficacy concerns with rounding down to the nearest vial. In recognition of this fact, we request ICER rephrase their wastage terminology to reflect that patients use HAEGARDA vials entirely, and this over-indexing yields additional therapeutic benefits without increased risk. We also ask that the assumptions around over-indexing and rounding are made transparent. As there are several pricing discrepancies in the current report, CSL would recommend relying on any one standard price benchmark for pharmaceutical prices, such as WAC, AWP, or ASP. Any one of these would allow comparison of costs each product using a recognized industry benchmark, which is used for reimbursement in the marketplace. In conclusion, CSL Behring sincerely hopes that ICER and its stakeholders find these comments useful as they contribute to refine the analysis of the HAE category and ultimate benefit of patients. And I welcome any questions or comments. Thank you.
Thank you. At this point, I'd like to invite Dr. Pearson or Dr. Ryan to make comments and moderate panel questions.
Sure. I was just going to, is this on? I'm still not able to tell. I just wanted to respond specifically to the wastage question, since we've had some discussions about that today. So one of the reasons this comes up, like pretty much everything else that has come up, is that this model, given the very high cost of on-demand therapy and the very high cost of prophylaxis, little changes like whether you assume no wastage or the wastage that was assumed have tremendous effects on the cost effectiveness of HAEGARDA, for instance. So that's why this comes up. It actually matters. The assumption made in the model was that if you weren't the correct weight to exactly use units, since these come in vials of 2,000 units and 3,000 units, that you'd get the dose you were supposed to get per kilogram of 60 units per kilogram. That would be calculated out, and that whatever, you know, if you needed a little bit more than that, you had to use the next vial. If you needed a little less than that, you'd have to throw it out. CSL Behring is saying that isn't really what happens. That if you need a little bit more than that, you get it. Okay, that's not going to make any difference to cost. If you need a little bit less than that, you don't bother to use another vial to get up to the full dose. We think we need to talk to some U.S. experts before the final version of the report is published to have more of a discussion of that, because it does, in fact, affect cost-effectiveness analyses. And almost everything that's going to come up, if we use 4 attacks rather than 3.39 attacks, that affects cost-effectiveness for all the drugs a huge amount. So it's going to be important, as you all weigh this, to listen to the experts and everyone else and think about how these things affect the results that we're getting. It's an unusual situation in that way.
Sorry, yeah, the choreography is a little distorted here. So just to continue a few more minutes before we break for lunch. Do any of the Any other response, I guess? Solomon, did you want to respond to any of the comments from Deborah? Solomon?
Just a comment around the percentage of patients or attacks that require additional doses. I think in your response, you gave us some statistics around the percentage of patients who require additional dosing of on-demand therapy. I think what might be more useful for us, is to look at this data in terms of number of attacks that require additional dosing. Then for the CTAF panel, just wanted to highlight that this is another variable that has very significant impacts on ICER, on the incremental cost effectiveness ratios. So small changes in those estimates pretty much change what the cost of acute treatments, or what the cost of on-demand treatments is, and that has a major impact on what we calculate as the final answer. So just like David said, it's something. It's another source of major uncertainty that we're going to have to grapple with.
I believe we can look and interrogate our phase 3 data and maybe come up with the calculation that you're requesting.
Any questions? Yes, Kim.
Follow up on the wastage question. How much? How is it stored? How cumbersome is it to mix it up? And Stephanie, what do you do with what's left over?
Maybe I'll let Stephanie start, and then maybe I can add some color to our experience and what we understand that's happening in the marketplace.
Discussed with my doctor, he said just use, I'm not over by much, so he said just go ahead and infuse whatever is mixed up. Don't waste it, just go ahead and infuse. It's not very much that I'm over. I don't remember the exact amount, but I just infused the entire 2 vials that I have.
And you keep it in the refrigerator, or?
No, I just store it in a closet. It doesn't have to be refrigerated. Room temperature is how it's kept.
And what do you mix it with?
I'm sorry?
How do you mix it up?
It comes with a mix-2 vial, and it's very, very easy to use. Both of my boys actually know how to mix up their Baronert themselves. It's the same concept for Haegarda as Baronert.
And I just wanted to help because I think the term wastage can be confusing because of the way that we often think of that as having some left over and throwing it away. What we're hearing is that they use whatever is in the vial. Now, that may mean that if they think they need 1.2 vials, maybe they just use 1. They don't open up another one and do all of that. Or they may open up 2 vials for someone who needs, according to the weight calculation, 1.2. So it's going to be an interesting, as everybody has pointed out, because there are so many variables with minor changes that can drive the cost effectiveness kind of gyrating in different directions. This is going to be one of those points that the clinical and the payer community and the patient community is going to have to think about carefully, because it does lead to some very different assumptions about the value, or at least the cost effectiveness, depending on what you think patients are going to do. Are they going to mainly go up, or are they going to somehow balance it? Now, the company has suggested that they have real-world information on this. Again, as Dr. Rinn said, we'll try to figure out how to triangulate sources, but this is going to be, there's probably never going to be a perfect answer to this, but I wanted to make it clear that this isn't throwing it away. This is figuring out how much of the time they'll go ahead and use it all, or actually, quote unquote, underdose themselves with instead, according to the weight-based calculation. Is that a fair way to describe it?
I think so. I mean, I would also add that, this is something that we address in plasma replacement therapy and other programs in the rare disease space. The clinical trial accounted for rounding. So when we use a unit-based, weight-based calculation for your baseline dosing, clearly your vial size makes a big difference because weights are very variable. So there was rounding calculations built into the clinical trial that you could round up or round down by 500 international units. And I believe, that starts representing sort of where physicians become comfortable with being a little bit over and a little bit under, and our general experience, which we'll share the data that we have with respect to the overall utilization at a dose within the community is just slightly under a 60 international unit per kilogram on average across weights and doses that are received by patients.
But each vial is single use.
That's correct.
Correct. Now, it's interesting, and we may take this up on the policy roundtable, but again, part of the challenge of not having multiple clinical experts from multiple parts of the country and different walks of life is that it sounds like, for instance, you're suggesting that the general feeling is that the more the better. So if that's the case, then why wouldn't people be on the tipping point of using that extra vial? Why not? Because there are no side effects. The only downside might be just more injection discomfort or something like that. So how that really plays out in the real world, again, is going to be an important part of judgments.
Oh, one last question, I think.
Oh, yes, sorry. Rita.
Thanks. Actually, now I have a comment and a question. So my comment is just particularly as a clinician and editor for a medical journal, when a trial was jointly designed by the sponsor and the investigators collected the data, but it was analyzed by the sponsor with input and medical writing assistance was covered by the sponsor, I think it introduces multiple sources of bias in a trial. And I think a high quality trial that is funded by the company would give the funding to the academic investigators and have a hands-off approach. So that's my comment. And my question is about the quality of life data in the cost effectiveness model, because there's a lot hinging on the quality of life data, but I didn't actually see quality of life data collected in the trial. So I'm guessing you imputed it from the number of attacks and went to other data where the Swedish retrospective study where they had some kind of survey response and retrospectively asked people about their quality of life. But I feel that that's probably not ideal for looking at quality of life, which is a big part of this model. So I'm a little concerned about that.
Solomon?
I mean, yeah, that's a major limitation of what we have as part of our analysis. I think the only trial that did collect EQ5D data did not see any difference between, I can't remember which trial this was, but I mean the study we use indeed is a cross-sectional study, and most quality of life studies actually come out of European studies, but even then I think. We just taking the data from that study. We tried our best to fit it within the framework of the data that was collected as part of the trial. So, for example, the proportion of patients who are attack-free, we try to account for that. We also try to account for. So we try to track periods when patients have attacks and assign a utility for that, and that data is there from the quality of life study. Then we also track periods when patients are attack-free, and we try to assign utilities based on that. So what I can say is it's always a challenge when it comes to modeling, especially when you have limited data. You can only do the best you can with the data that's available, and also try to use all the data that you can come up with.
David, David wanted to chime in on that, and then
I just wanted to make one more point on that in terms of the importance of the quality of life data, which is that for both Haegarda and lanadelumab, within the ranges of reasonable numbers, they become dominant. So unless you think that we're going in the wrong direction and quality of life is actually decremented by these therapies, within the ranges of reasonable things like attack rate, they're cost saving, unrelated to quality of life. So we can't just look at the quality of life numbers and go, well, but for, if we assume a different quality of life, we'd end up with a different quality, dollar per quality, because we're actually saving money once the attack rate gets somewhat higher than the baseline attack rate. So just as you're thinking about all that, yes, there's a quality issue there, but even if you took that out of it and you assumed no benefit on quality of life over the range of reasonable attack rates for those two drugs, you could imagine them being cost-saving. It's very hard to see where that would happen with Cinryze.
I mean, I would just point out that, I mean, I think you did an excellent job with the data available, but that is all simulated. I mean, you were talking about a 14-week trial, and then you were talking about lifetime, cost saving. We don't have that data, and, sometimes real world is different than what you're simulating. So I just think that's a major limitation.
Right. Now we've run over time. Can the questions that you guys have hold for the deliberation around the votes? I'm hoping it's going to be of that type, and we'll be able to return to the policy issues when we get to the policy roundtable. So I'm going to go ahead and push beyond the time that we had allocated for lunch. So we will be restarting at 12:30 on the nose, which is 10 minutes later than previously. We'll carve it out of some facet of the voting and the policy roundtable. But thank you very much. We will be reconvening right at 12:30 to start again, and we'll hope to have the audiovisual issues sorted with our clinical expert. Thank you.